Good evening. Welcome to this session. We will be talking about the economics of FGM tonight, a very interesting topic and something that I think is not discussed very often. Our guest speaker is Hilary Burrage, and I'm going to just take a second to introduce Hilary. Excuse me. She's a sociologist, a consultant, a teacher, an author with a very, very wide experience and knowledge of numerous different topics. Hilary, I kept this very short because you see it's so impressive that I would not be able to get it onto one page. Hilary has published two books on FGM called Eradicating Female Genital Mutilation, a UK Perspective, and Female Mutilation, the Truth Behind the Horrifying Global Practice of Female Genital Mutilation. Now, before we go further, I would like to read just two short pieces from the preface of the second book, Female Mutilation, the Truth Behind the Horrifying Global Practice of Female Genital Mutilation. And the first one is, during the last 30 years, the biggest challenge for those who fight for the elimination of female genital mutilation has been to make the world understand, as this book demonstrates, that FGM is not an esoteric phenomenon belonging to African tribes lost in the African savannas and forests, to whom the rest of the humanity must pay absolute respect. On the contrary, it's a clear violation of the rights and the physical and physiological integrity of girls and women wherever the practice exists. And then the second piece, and this to me is really so important. What can I do to participate actively in this wonderful human adventure to free the world from one of the most absurd traditions detrimental to the rights, the health, and the life of women and girls? And that's coming out of the preface of the book, Female Mutilation. Just a little bit of an overview before I'm going to hand over to Hilary. Most of you have seen this deck already, or have seen this slide, and would know that every 11 seconds a girl in the world is cut, and that more than 200 million girls in those countries where data population exists have already been subjected to FGM. So we know that this is an incomplete picture. And as I've said many times before, and as Hilary will reiterate tonight, FGM is not just an Africa issue. But if we want to stand still just for a moment about the situation in Africa, this is a fairly recent map that I found. We will share more information following this discussion about the incidents. But as you can see, there are a number of countries where the incidence or the prevalence of FGM is more than 85%. If you go on to Hilary's page, there's a really interesting blog that she did recently for a group called Oxford Against Cutting, and this is where I saw Hilary the first time and thought it would be really interesting to ask her to do a similar presentation for us where we can talk about the economics of FGM. Hilary, it's my privilege now to hand over to you and to ask you to start talking about the topic. We're going to keep it fairly informal, and there will be an opportunity for questions and answers once Hilary has gone through some of the high-level detail. Hilary?
Right, thank you. Thanks very much for inviting me to speak. I'm going to speak in a way that I hope will include people so they can contribute ideas too. Let me just run through for 10 or 15 minutes what I'm thinking, and then hopefully there will be lots of things to discuss from that. So, okay, we know that FGM comes in various shapes and sizes, that it is always a human rights abuse, always, without any question. It is mostly done by women, but because they believe men require it, not because they're doing it on their own. And in fact, one of my, I don't know if I'm going to be able to show you this, but this is my, let me just put that up. That is my serious belief about it. I don't know if you can see that. FGM is patriarchy incarnate. It's the imposition of men's will, some men, not all men obviously, onto the bodies of women for, in my belief, mainly power and economic reasons. When I say economic, I mean money and resources and the imposition of power on other people. So it's an abuse because it's harmful and it hurts, and it's also an abuse because it is an attempt to subjugate women to the will of powerful men. Sometimes that includes powerful women, for instance, who are the cutters, who have status from being cutters, but they've always, almost inevitably, always been cut themselves, and they're carrying on a tradition which is what they understand to be the right thing. I, of course, totally disagree with that. I managed to print this out. You probably can't see very much, but you can see that there are, as we've just been told, blobs on the map, which are very high incidence of FGM. It's important to understand that FGM doesn't go by country, although we have to measure it in that way. It goes by tradition, by what is called, but it's not really culture, I call it socioeconomic impetus, if you like. It belongs to certain tribes and certain ways of doing things and certain understandings. So you can measure the incidence of FGM in one country and it looks really low, and another one it looks high, but that's because actually the blob of land where it occurs is across the boundary and more in one country than another country. So whilst we do have to keep to national boundaries in doing the measurements and looking at the impacts, it doesn't actually tell us what the impact in a particular region is, because the region may include 2 or even 3 or 4 countries, depending on where it is. And I'm a sociologist, not a literary person or in any way talented in those ways. Most of my colleagues I work with are either medics or lawyers or literary people. And they all have absolutely essential roles to play in this. And in that I count people like teachers and social workers as well. Everybody has a role to play in trying to stop FGM. But I have never worked in the field, and in fact for various personal reasons I couldn't. But I don't think that's my role anyway. My role is to try and look at what is the lever that is going to let us stop FGM. So I regard it as a fairly fundamental level at which I'm trying to work. And I did look at some figures here. You probably can't see the figures, but I looked at countries that have, I'll share this later. I looked at countries that have types 1 or 2 FGM, which is the cutting and removal of flesh. And there's something called the Human Capital Index, which is telling us how much of human beings in that country have been developed to contribute to their societies, not just economically, in many, many ways. And for countries that I chose, and I included Tanzania, although it's quite a small incidence because we just read the book about Tanzania, and I thought that was interesting. The Human Capital Index averages at 41. Ideal would be 100, but nobody gets over about 80. For the type 3, and that's various countries, Djibouti, Eritrea, Somalia and that, there aren't any data on this stuff. It's very difficult to get data on things like that. The World Bank is still working on it, but they haven't managed to get to those countries yet. For countries which are very low, and I've got Canada, Germany, New Zealand, Norway, Sweden, UK, USA, the human capital index on average is 66 compared to 41. Gives you some idea. This is just finger in the wind, see how it's going, just to look at it. If you look at the world rankings of countries, and I found Egypt, Kenya, Liberia, Nigeria, Senegal, Sierra Leone, and Tanzania as a range of likely countries. I couldn't get the data for Iran, Iraq, Pakistan like that. It doesn't really exist as yet, not properly. If you look at the world ranking of those countries with the type 1 or 2, the average out of 228 is 196. If you look at the 3 that I found some data for on type 3, the average is 219, including the very lowest of all, Somalia. If you look at the average for the world ranking of the countries I mentioned with very low incidence, mainly because of the diaspora rather than, not always, but mainly because of the diaspora that has an incidence at all, the average world ranking is 18. So you've got 18 for the countries in the first world that have little indigenous or originally indigenous FGM. You've got 196 out of 228 on average for the ones that do types 1 or 2. And of type 3, the average is 219, almost at the bottom. These do not of themselves tell us it's FGM, but they give an indication of how direly important it is to stop FGM, to help these countries to raise from where they are to something more, more comfortable. I looked at maternal mortality rates as well per 1,000 people. For the type 1 and 2, the average maternal rate for the year 2017 in the World Bank is 557. So over 500 women die for every 100,000. If you look at the one for type 3, it's 852. And if you look at the one for FGM very low, it's 8. I think that illustrates the stark differences between various countries and what happens. And again, let me say, I'm not saying this is all caused by FGM, of course I'm not, but I'm saying, doesn't it show us that it's really direly important to look at things like FGM to see what we can do to make for a more even, a fairer, a better world for everybody. So we've got here a number of other things about cost that I found. This is the World Health Organization telling us that is how much they reckon it would cost to treat FGM, women who have FGM, to make them well again. And I think that is just the medical costs, not the psychological costs, not the social costs, not the rest. That's just to treat them, to make them well. This is from the World Health Organization too. They are convinced, they know that that is how it is. I think people can see this, can't they? You can see. It says, when countries invest to end FGM, communities are stronger and healthier. This is from the UNFPA this year, FGM maternal mortality rates. I'll show you in a minute. Very recent estimates by WHO, UNICEF, UNFPA, the World Bank and United Nations Population Division reveal that most of the high FGM prevalence countries also have high maternal mortality rates, high numbers of maternal deaths. 2 high FGM prevalence countries amongst the 4 countries with the highest numbers of maternal death globally. 5 of the high prevalence countries have maternal mortality rates at 550 per 100,000 live births and above. Pretty dire stats. And I'll come to this other one in a minute. So we're looking at something where we know that women of FGM are more likely to die young. We know that they're less healthy, so it's harder for them to do their work. It's like PERDA, which actually damages women's health and makes their prospects more difficult too. We know that FGM prevents education because people leave school. We know that if you don't have FGM in some communities, you're not adults, so you're not allowed to own land, which is much, much more important than people understand it to be, generally speaking. The ownership of land, which is a very difficult issue in many parts of the developing world, if I may call it that. The ownership of land is critical. if you don't have FGM in some countries or an equivalent procedure of whatever sort, you're not adult, so you're not allowed to own land. You can't even own land to feed your own children some food. This is pretty dire stuff. And then something else just very quickly, that I was reading The Economist, and as I say, I'm trying out ideas with you. And it was looking at the incidents, questions about the current virus and the impact of it and how economics has been measuring it. And it was talking about disparities in income and wealth. I'll read it to you. I cite it here. The other economists look at the distant past to explain contemporary disparities in income and wealth. A paper from last year by Benjamin Epke of Harvard University finds evidence that pre-industrial ethnicities were exposed to a high local prevalence, of pathogens exhibited tighter kinship systems, meaning in effect that people were strongly loyal to their extended family but suspicious of outsiders. In a place threatened by disease, tight family ties were beneficial because they reduced the need to travel and therefore the risk of being exposed. A lot of the communities we're talking about are still much like the ones that really adhere to FGM. Places which had tighter kinship systems those years ago tend to be poorer today, which is a relationship that emerged during the Industrial Revolution. So the tight kinship systems which confirm in people's minds the need to do FGM are also in themselves systems which perhaps actually hold back the development that would make for a more comfortable and healthier life for all these people. I want to stress and say this, I'm not saying that capitalism is better than any other system or anything like that. I'm simply looking at opportunities for education and knowledge about how to maintain health in terms of feeding your family, all sorts of things, and having good health. And these things are less likely to occur in places where there's tight kinship systems of the sort that demand certain practices be maintained, cultural practices, historical practices, traditional ones, that they be maintained and not moved, not changed. So we have a system where communities may be tight and that may make it more difficult to move away from FGM. Communities that impose a lot of FGM inevitably harm the people they do it to, the women who undergo it. And that harm may be psychological as well as medical or sociological. And there's also quite strong evidence now that people who have FGM may well suffer from post-traumatic stress, which again means that they are interknit like this and they don't want to go to anybody outside their community. This is not a criticism, this is me trying to explain how these communities seem to be so tight-knit. Other people may have different explanations and I'd be interested to know. So we've got a system where it's really difficult to know how to tackle it. So what I wanted to say is, I think that by looking at some of these issues, like FGM results in early marriage, loss of education, personal opportunities, it's known to increase the likelihood of maternal infant mortality. Maybe it doubles it. When a woman dies, her child has less chance of living beyond the age of 5. There are mental and physical health problems, obstetric fistula perhaps, psychosis, PTSD, exclusion from communities, all those sorts of things, particularly if you get fistula. People who have suboptimal physical and mental health are unable to contribute fully to their family groups and their communities. The medical care of women and girls with FGM adds enormously to costs which should be spent elsewhere, which is what we have just now. Women with FGM lose a bit of their lives as well as some quality of life. They also die younger. That's not surprising, really. And FGM reinforces gendered stereotypes in communities, holding back optimal engagement by both men and women. If we can say those things, and if we can begin to measure them, we can say to the politicians, we're not doing much about it. Why aren't you tending to these things? Because these things are holding your country back. These are really serious matters. In many of the countries we're talking about, and we've looked at the disparities already between different sorts of communities in different nations, this is something that is really damaging your, when I say economic prospects, I don't just mean economic, I mean quality of life, ability to feed people, all these other things. So I've moved from being somebody that is just, as we all are, absolutely horrified that anybody has to go through this awful experience, and it's a human rights abuse, to somebody with a sort of political side to me is saying, why aren't we using these levers to say to people who are ignoring it, you really must pay attention. FGM is almost, not quite, but almost the only epidemic, which is what it is, pandemic in fact, which can be stopped simply by people stopping doing it. If people don't do it, there's no more epidemic. It's not like typhoid or something where you've still got to find out who's got the germs and who's spreading them around and things like that. Just say stop, and it stops. So, and I know it's not, I do know very well it's not that simple, but sometimes I think you have to be hard-headed as well as warm-hearted in these matters. And I think that is really what I most wanted to share with you, to see how you feel about it. Over to you.
Thank you very much. It's interesting when you spoke about the different indices and the correlations that you made. I've never looked at them like that, but I certainly will look at that, because we know that the health impact is vast. But as you said, Hilary, it's also all the other aspects that's coming in, lack of education, etc. So there are so many different contributors. I don't want to be the one that's doing all the talking. So there's a question from Pam. Are there any countries that have effective programs to try and end FGM? If so, what are those programs?
Others may have different views, but I would say that Kenya is one of the places that is tackling it best. Actually, very, very difficult. There's not adequate infrastructure, even roads, some like Tanzania and all the other places in that part of Africa. Very difficult to reach all the places where it happens. But they do have laws that they mean to adhere to, and they do have. I know personally that the prosecutor who was in charge of implementing the first program, Christine. I met her in Washington, DC, actually. There are people there very serious about, and people do get arrested and sent to jail and told that they've got to think about it. And when they come out, they've got to change their minds. There are programs, as there are in Tanzania and some other places too, for rescuing girls from FGM and going to school instead. So there are countries where there is serious effort. It is always underfunded and under-resourced, and it is always very difficult because you've got to have a very mature legalistic and social infrastructure to be able to deliver it properly. But it's happening, yes. The problem, just to add, is that because the birth rate in many places is quite high, even if you stop X number of girls being cut, more girls are getting born. And the problem is to get the rate of cutting at such a rate that it exceeds the rate of extra births, because children are now living, not dying young, so they're living to teenage years and are subject to cut. That's quite a difficult one.
Just to add to what Hilary said, I think the reason, Hilary, and please correct me if I'm wrong, is the fact that in Kenya, the president has made quite a big commitment to eradicate FGM by 2022. He also has admitted recently that COVID-19 will have a very significant impact on those efforts. But over the past weeks, there have been a call to clergy to become much more active in preaching anti-FGM sermons and to spread the word that this is not a good practice. So I think it's a commitment from a very high level that's potentially also contributing to the difference.
The global media campaign with Maggie Kane, with whom I worked at The Guardian, is going around various countries in mainly in Africa, and talking to religious and political leaders and saying, mostly men, obviously, come on, we really have to have you to deliver this message. And it's using young people to put the message out, young journalists and what have you. And it's having quite an impact. I mean, the UN is taking notes. There's quite a lot going on there. You're right. I mean, the other thing to add in is that also you've got to prosecute those people that are doing it as a medicalised issue, particularly because in Kenya, to some extent, in Egypt, almost entirely, in a few other countries, quite largely, it's actually clinicians who do it. Yeah. And they earn extra money. And that might be because they haven't been paid for 3 months. You know, so the infrastructure has to actually make sure that people who are in positions of power are not abusing that power either because they want to or because they're desperate to feed their kids. And that is part of the legal thing to go. So you need to have the religious side and the encouragement from religious leaders and people at the top to stop it. And you also have to have a very hard-headed approach to people who are doing it, I think.
Hilary, there's another question. Do they talk to people about the economic disadvantages of FGM commonly in these places? If not, why not?
Okay. I think as we discovered in discussing Tanzania and the book there a couple of weeks ago, schools will tell children, for instance, if you have FGM, tell boys as well as the girls, it's really important to tell both. You know, you're not going to be able to carry on your education as you wanted to. You may be poorly, all sorts, you know, you're going to end up early marriage, which is, of course, early marriage occurs because girls' bodies are sold to men. It's a very economic transaction, that. Mm-hmm. This is going to happen to you. The difficulty is persuading large swathes of the communities involved that girls should get education and what have you, because, as you say, FGM increases the stereotype of what girls can do and what they can't do. And it's really difficult to persuade people to move from that to a view that everybody is equal and everybody has equal potential to develop, which is why I'm really keen on this human potential work. Probably it will happen most easily if we can persuade young men that they don't want to marry girls that are cut, that they will protect their sisters and their girlfriends from being cut because they don't want to have her harmed, and they do understand that her education is more important than being sold off for 3 cows when she's 13 or whatever is going to happen. I mean, it's so opposite to the way that most Western people think that it's quite difficult to understand. And I would add to that too, I know quite a lot about what happens in places like Iran and Iraq. I work with colleagues who are involved there. And even their understanding of marriage is different from ours. You would have a temporary marriage just for a few hours if you want, if you're a man, needless to say, not if you're a woman, and so forth. So there's an awful lot of things that we still don't fully appreciate and understand in this. And I'm trying to get underneath it. So it's a very good question. If not, why not? And it probably take till next year for us to explore all the reasons, if that helps.
Anne-Marie, do you want to ask your question?
That's okay, you can.
So Anne-Marie said or asked, in the documentary In the Name of Your Daughter, a man in the market said stopping FGM hurts everyone since he won't sell new clothes for the ceremony. Is this just there in that area, or is that in other countries a source of the problem as well?
No, it's FGM comes in so many guises and so many different life points that it's difficult to generalize. So whenever I answer these questions, I'm talking about a particular instance, not, you know, like if you do it when a child is a few days old, just as part of a package where she has a ear pierced as well, then it's going to be very different from if you have the full ceremony and the tribal African sort of way of doing it at say 11, 13, something like that. The ceremonies can be very big and important, and they're often carried out in that context, let me stress, not in all contexts, in that at points where, for instance, the harvest is good. So the cutting season, as it's called, will be different in different parts of, for instance, Africa, because the harvest arises at different parts of the year. And there's a very good example, I think, in the female mutilation book of a friend and colleague of mine who's basically a social geographer. She was studying land use in one particular country, and it was doing very well, and they were selling the produce and making a bit of money, what have you. She went once and all the produce was just lying on the ground, ruined. And it turned out it was the biennial FGM ceremony, and they'd all gone away for a fortnight, had an enormous party, were not remotely interested in tilling the land, lost a lot of contracts and so forth. So yes, I mean, it's all kinds of economic impacts that occur and don't occur because of this. But of course, the way around that, if you can get to it, is to have alternate rites of passage, where you still have, which is like a bit like an elaborate coming of age, where you have the party and you have all the food and the gifts and everything else, and that keeps people, the flowers, everything, keeps people in business without harming the girl.
It's interesting that you mentioned that, because that's one of the cornerstones or outcomes of SAFE as the target project, and unfortunately will be impacted by COVID-19. So we are looking at alternatives, maybe smaller ceremonies. Annalise asked, except for making donations and talking to people to raise more awareness of what is happening, what is there that people like us who are not directly impacted by this do to contribute and help the fight against FGM?
It's a very good question, one that I quite often get asked, actually. I mean, the first thing I'd say is never let those with influence in our own countries or anywhere else forget. I mean, there's a big, COVID is absolutely, utterly awful, but there is a huge risk, and it's already occurring. There's going to be more violence against girls and women whilst that occurs. FGM is going to occur without being stopped because it's so much more difficult to mobilise the legal and other authorities to stop it, this sort of thing. Don't let people forget this is an epidemic, a pandemic, in fact, which has been going on for decades, hundreds of years, in fact. And it's easy for it to become a side issue when more interesting things are arising all the time. So that's the first thing. The second thing is make sure that in your own country there is a decent amount of support for people who need treatment and help in your own country, because in the end, one of the very best ways is to persuade people when they come to one of, I say our countries, I mean a first world, more privileged country, that they really don't need to do this anymore. Because when a girl in a Western country has it and she becomes marginalised, she's sort of double disadvantaged after that, because she's already in a minority organised community, and then she has something which hugely impacts on her health and her well-being and her mental state, quite probably. So we can always make the message by making sure that we look after the people who are vulnerable in our own communities. I've always been very reluctant to lecture people from other communities, because I don't understand enough about them to always make the right call if I do so. So I try to stick to the things that we can do, we can do honestly, because we do know this hurts and so forth. So that's the thing to stick to, rather than telling people somewhere else exactly how they should be stopping it. That's a local decision, I think. Does that answer the question?
Yeah. Another question from Pam. You mentioned Kenya is using its judicial system to enforce rules, but is any government trying to provide real economic incentives not to do FGM?
I guess they'd all say they are. I mean, it depends at what level of, what dimension incentive becomes. I was reading again, drawing on because it's been a project for your organisation, Book About Tanzania, and they can only take forward the girls that they decide through exams are bright enough to carry on. Maybe that's where we can all come in by saying, well, actually, we know that technical trades, agriculture, etc., are just as important as degrees. In fact, in some communities, probably more important. And that if we're really serious about this, this is where we need to be encouraging governments to support, and maybe we can help in that in some places. I mean, there are organisations like WHO and the World Bank and that which know far more about it than any of us can. But yeah, the countries try, but sometimes they are, I think, held back, and I mean that respectfully, by the fact that they're emulating a system which probably looks good and is the ideal, but doesn't actually meet the local need as much as maybe a bit different one does. That's a bit of an equivocal answer, I know, but it's quite difficult to articulate because there's so many aspects to it.
Okay. Roseanne, in Western countries, what is the obligation of the healthcare team in regarding to reporting system mechanisms, if any? Is it naive to think that with the economic impact of post-FGM, are there some circumstances or villages that would consider being given the payment of cows or having a coming of age celebration with financial donations?
Right. Yes. There are some instances of families being promised money, sometimes by superstars and sometimes by political organisations, if they can prove consistently through the school years that their daughters are not cut. You will have the money so long as your daughter is not cut. That is, of course, quite an expensive thing to do on a large scale. It tends to be just some girl sponsored for that reason. I guess the proof has been the pudding. You know, we have to show that girls who have not been cut do better in their lives, and we're fairly near the beginning of that curve. You know, because girls who've been rescued from FGM in any number are probably still only in their 20s, maybe 30, but not very old yet. And it's going to take quite a while for them to be in positions where they have huge influence. And so we have to keep feeding the channel through to show it works. It's going to take a long time. It is possible in some instances to stop FGM by saying, if you don't do it, we'll give you money or some such. But whether it's feasible at large scale, I don't know. I think it has to be example rather than incentive of that sort. Maybe I'm wrong.
Roseanne, to add to your question, when I was training as a physician in South Africa, that was the late 70s, early 80s, there was no mention in our curriculum at any stage about FGM. It was not a topic that surfaced. We spoke, male circumcision was included because it's something that's quite prevalent, but FGM was not mentioned, and I think that's a gap in many medical curricula, medical and curricula worldwide, that there's just not enough awareness of FGM. I was reading a book a while ago written by a British registrar. He was on his way to specialize in obstetrics and gynecology, and he was working in an ER one day, and a young woman came in with obstructed labor, and he did not recognize FGM. So it's not even an issue that we didn't pay attention to 50 years ago, 40 years ago. It's still an issue now. So I think medical and nursing schools need to do much more to make sure that physicians and nurses know about this and know enough to be able to support their patients. Now, I know, Hilary, that there's a lot of work being done around this topic in the UK to create more awareness in the medical and nursing community. Do you want to comment on that?
Yeah, it was, thank you. Yes, I mean, an example. 2-3 years ago, I was asked to go and talk to the North Wales Obstetrics organisation, mostly consultant obstetricians, gynecologists, with some PhD students and others of that sort. And I went and was pleased to do it. Only about half of them actually knew anything about what I was talking. They kind of vaguely knew. But when I said, do you realise it happens, as it happens in Wales, which it does, particularly in Cardiff, because that has quite a migrant community, they were really shocked. And I thought, well, that's interesting, because they're sufficiently worried and aware to ask somebody to come talk about it. But most of them didn't. I mean, they all said to me afterwards, thank you, yes, that was very interesting and all the rest. And, you know, we did the handouts and the rest of it. Everybody was fine. But the upshot, I don't even think that it's now just medics, or when I say just medics, I mean that respectfully, who need to know. I'm talking with some other colleagues. I'm trying to sort out an organisation that will be FGM studies, a cross-curricular, cross-disciplinary module that would be put into most personal professional training. So if you're a doctor or a teacher or a social worker or a lawyer or whatever, you would need to have this module or one moderated to your own professional organisation, obviously, in your undergraduate study or whatever the equivalent might be, because many people are scared to deal with it because they're not quite sure whether they're going to be doing what the law says. That, of course, it's all on the website, but as any nurse or doctor will tell you, well, I haven't got time to read websites all day, I'm busy, or teacher or anything else. It has to be something that is embedded in their understanding of their own practice, their professional practice. So we're talking about how to make that part of what it would be, not only just in the UK, but anywhere you can think of. Any good professional practice would include an understanding of this. And of course, one of the difficulties is that the law is different in every country. But then so is the law for anything to do with personal protection and protecting children, and that the law is always different in different places. You can compare Scotland and England if you just want one example. Take it to France, where they don't have a legislation against FGM, they just have one against assault, and it's been very successful. My friend Linda Valcuriel has prosecuted men, or been responsible for prosecuting dozens and dozens of people who've done it, for instance. The law is always different. The teaching practice will be different. There will be different rules about when you have to disclose and who you have to disclose as having it. Is it only under 18s, or is it everybody? Is it obligatory as somebody in a regulated profession to disclose it, or can you get away with it if you don't think it's going to happen? There's lots of variables, but the core understanding must be there everywhere. I think that is something we can all do something about. We can all be saying to our own co-professionals, why isn't this compulsory in the curriculum? It could just be, I don't know, 5 lectures or something, but you have to understand it, and it has to be core.
Yeah. Katia is asking, does the European community show awareness on FGM? And are there any actual laws, initiatives taken to say no to hospitalized versions of FGM? Give every woman living in the Western society a suggestion of what she can do in order to contribute to actively stop FGM. What would that be?
Yeah, there's this paper on medicalization of FGM. Unfortunately, I can't get printed across it, but yeah, there are now a lot of academic professional papers on medicalisation. WHO and UNFPA are probably more worried about medicalisation than any other aspect at the moment, because the story goes that, oh, if it's just a nick and if you have it done by a doctor or a nurse, you'll be okay. Dentists do it too, chiropodists do it, all kinds of people do it. They know how to do pain reduction. they know how to use a sterile knife. It'll be okay. Well, it is not okay, is the message. And there are physicians in the States, for instance, who argue that still, that, oh, well, it's better than having a big process done with, say, a nail or a dirty piece of shell or something you don't want to think about, awful like that. There's two reasons, well, many reasons. One, first of all, it's absolutely against any sort of ethic that a medic or a teacher or a social worker or anybody else would subscribe to. And for medics, particularly with Hippocratic youth, that is really important. They all subscribe to that when they graduate. And it says, do no harm, or words to that effect in every version. Secondly, it's done for money. And that makes them criminal, in my view. And thirdly, there are lots of examples of people having the medicalized version because that's what everybody says is. And as soon as that's finished and it's all over, they go somewhere else and have the other version done as well, privately. It can't. And how do you get, if we talk about medics, we could talk about other people who are in regulated professions, but talking about medics, how can you insist that people report this every time they know about it, at least in under 18s, if at the same time you know some of them are getting away with actually doing it? And whatever you call it, and there are huge issues around, other genital surgeries that are cosmetic and what have you, and particularly when they apply to young people. And I'm not trying to tell you, but this book, I've got a chapter in, and it actually explores that stuff because it's really difficult to maintain that cosmetic surgery is okay if FGM isn't, and people accuse us of being hypocritical. My view is that if we put aside adults who are not vulnerable, because many are vulnerable, but adults who are invulnerable, and leave that debate for later, doing anything like that on a child is, well, in my view, unforgivable and also unethical and probably very medically dangerous, because messing about with stuff before maturity is a very throwing the dice, not knowing where it'll land, isn't it?
Yeah. There are quite a few questions, so I think if we can go through them fairly quickly. Anne-Marie asked, do the girls who don't get cut tend to move away, therefore their success or lack of it isn't seen? Are there any studies on that yet?
They probably move from small villages to larger towns, maybe university cities. But of course, the hope is always that they will at least, and there is no obligation on anybody to do anything. If you want to move away and live your own life, well, who are we to tell you that you can't? But the hope is that many of them will go back as teachers or nurses or doctors or whatever to their own regions and be able, because they understand underneath what's going on, they will be more effective in combating this sort of disadvantage. But, no more than I would say to anybody, you're a woman, so you've got to speak up for all women. Would I say to somebody that happens to you, you've had the privilege of education, so you've got to go back and use it. It has to be something that people want to do. But I think there's quite a lot of evidence, well, even in the book, as you know, that people do, including young men. It's not only women who come back and want to do things. There's quite a tranche of young men who are equally determined.
Yeah. I think we're going to make the next question, Hilary, the last question. There are 6 other messages. What I would like to suggest is that we go through that, you and I, tomorrow, answer that, and then send those replies to this group so that everybody has that information, because otherwise we're going to sit here until 9, and that's not the intent. So the last question then for tonight, if young men are taught the negative effects of FGM and understand a healthy wife is a woman who has not been cut, there would not be a market for girls who had undergone the procedure. So why are the mothers so adamant to have their daughters go through this atrocity, having gone through it themselves and knowing how painful and dangerous this procedure is? Is it social pressure, pride, ignorance, or just our tradition? That's a loaded,
okay,
lots of pieces to it.
There's lots of historical, traditional impetus in that. We must never forget that for, not every time, but nearly always, the rationale for FGM is purity. That's the presented rationale. I mean, I actually think that there's a lot of money involved behind the scenes, but the public rationale is to maintain purity, to stop young women having multiple affairs or going off with this and that and the other, things like that, to make them pure wives. And there are huge differences between different countries in the level at which that is important, huge differences. And in a way, we have to move beyond that to saying, how interesting that you're saying that this is what's going to happen. I wonder how much money you've made from it, or how much power you've got from it. And do you actually want your wife to be your equal, or do you want her not to be equal? And things like that. And those are questions, I mean, I can ask them as a sociologist all the time, but they're pretty well meaningless to a lot of people, because that's what happens. You know, and I'm just being impertinent by asking the question. So I think there is scope through example, and that's why it's so important to get to the people at the top and say, look, not only are you ruining the lives of the people concerned, but you're ruining some opportunities for your communities, and you have to think, is this really what you want? But education of young men is absolutely, and under the men too, but absolutely critical. My friend Camille in Iran, he interviewed lots of men, and they get to the bit about, do you know it's painful and that? And mostly people don't know very much about what happens, the men. I mean, they probably know more than they let on, but they don't. And all you get, I'm told, in response to that question, do you know it hurts and do you know it's dangerous, is no response at all, because people are embarrassed to face up to it, which is understandable if that has been your belief and if you have believed erroneously that your religion requires it. Or I must say that animists are very often involved in this too. It's not just standard religion. There's all kinds of, and some Christians have done it and some Jewish people have done it. It's not just one group of faith, but it's very difficult to have those fundamental beliefs that you've just grown up with challenged directly. So there has to be other reason to change, like it's harming your community or something like that. I keep going back to that, but I really think that is, and I hope I'm not avoiding the question, am I, by answering in that sort of way? Is that an answer?
Yeah. Well, I would like to bring this session to a close. Hilary, thank you very much. Thank you for making the time available to have the discussion with us. It's not an easy topic, but I think through these discussions that we're having and sharing information, we are starting to understand aspects of it. I don't think we will ever be able to understand it completely because it's just too complex. But thank you for making the time available tonight to provide your knowledge or share your knowledge with us, and to everybody that joined the session tonight. Thank you very much for joining us and for all the questions. Anne-Marie and I will work on, or Anne-Marie will work on the recording. We will look at all the questions to make sure that they all have been answered, and we will share that with you as soon as possible. So thank you very much, and good night to everybody.
Thank you. Thank you very much.
Thank you.
Thank